Pain Management, Evidence-Based Practice by Taylor, Madison, Jeremy, and Kelly.
Background and assessment. Pain is cited as the most common reason Americans access the healthcare system. It is a leading cause of disability and a major contributor to healthcare costs. Most commonly, the management of pain is done with analgesics and physical therapy. Oftentimes, medication is given around the clock, and patients still seek more due to the pain they are in after a procedure. Post-operative acute pain management is followed by many negative consequences. These include increased morbidity, decreased physical function, decreased quality of life, slower recovery, opioid use throughout and after the hospital stay, and increased cost of care. The problem was identified as patients' continued use of analgesics after hospitalization. The unit type for this problem would be the PACU, the post-anesthesia care unit. The level of care is high. There is consistent monitoring of vital signs and pain levels depending on the protocols of the procedure that was done and the doctor's orders.
So our PICO in question. The population is the patients that are needing pain management postoperatively. The intervention is integrating essential oils as an intervention for pain management. Control. The control is the standard postoperative care, which is analgesics, physical therapy, occupational therapy, and nursing care. The outcome. The overall mean pain scale is less than the experimental group versus the control group. Time is to assess the pain levels immediately post-op, 8 hours post-op, 24 hours post-op, 7 days post-op, 30 days post-op, and then 90 days post-op. The question, among postoperative patients, what is the impact of adding essential oils versus standard pain management on pain levels over a 90-day period?
Why change? Standards in pain management are not enough. Patients are still in pain, not satisfied with their care, staying longer, going home on pain medications, and a majority of nursing time is spent trying to manage patients' pain. Using essential oils in adjunction to standard analgesics can decrease the length of hospital stay and the need for opioids. Pain is common after almost any surgical procedure, although analgesic medications are effective in reducing pain and nausea. Uncomfortable side effects can prolong the healing process and increase hospitalization time. A study showed that using eucalyptus aromatherapy lowered blood pressure and pain levels. Another study showed that lavender aromatherapy caused greater patient satisfaction even though pain levels were reported the same. With using essential oils in addition to standard pain management care, you can increase patient satisfaction and decrease pain. Additionally, the cost associated with aromatherapy is far less than the cost associated with standard pain management and treatment. Decreasing cost is also an incentive to increase the use of essential oils at the hospital. Patient satisfaction is important for reimbursement and public data publication. This leads to a question. Among postoperative patients, what is the impact of adding essential oils versus standard pain management on pain levels over a 90-day period?
There's a lot of different essential oils that are used for pain, all different types of pain, headaches, neuropathy, joint pain, inflammation, arthritis, but some of the most commonly used ones are chamomile oil, which is for pain and inflammation, lavender oil for pain, eucalyptus oil, which is used for nerve pain and sinus pain and pressure, peppermint oil, which is used for headaches, muscle pain, and joint pain, rosemary oil, which is used for inflammation and chronic pain, and sandalwood, which is used for inflammation, joint pain, and muscle spasms.
Current research. The effectiveness of aromatherapy in reducing pain. Systematic review and meta-analysis by Shaheen Lakin, Heather Schaefer, and Deborah Tepper. This was a meta-analysis of 12 separate research articles. The first one was a randomized controlled trial, double-blind. Diagnosis, renal colic, the intervention, rose oil and vaporizer, and conventional treatment together. The results showed that there was no significant difference upon initiating. However, 10 and 30-minute VAS scores were lower in the intervention group. Randomized control trial for hemodialysis patients. They inhaled lavender oil during hemodialysis treatment. The VAS scores were shown to have decreased in the intervention group as compared to the control group. Clinical trial single blind for those receiving cesarean section. The intervention was lavender oil and face mask with oxygen. The intervention group experienced a decrease in pain in comparison to the control. In a randomized control trial for those with postoperative knee pain, the intervention was inhalation of eucalyptus and gauze. The VAS pain scores were lower on all 3 days than those inhaling the almond oil as a comparison. In a clinical trial semi-experimental for those in labor pain, the intervention was lavender oil on swab attached to the patient. Mean VAS scores of intervention groups were lower at 30 and 60 minutes. In a randomized control trial with hand and ice water, the intervention was a lemon and oil diffuser. Both odors produced significantly greater pain at 5 minutes. At 15 minutes, those exposed to the unpleasant odor experienced greater pain than the control. In a randomized control trial, double-blind, for those with menstrual pain, the intervention was self-massage with lavender, clary, sage, and marjoram. Pain decreased after 1 menstrual cycle intervention in the 2 groups. Pain reduced from 2.4 to 1.8 after the aromatherapy. In a randomized control trial following an episiotomy, the intervention was lavender oil and sitz bath. The statistical difference in pain levels at 4 hours and 5 days. Results were insignificant at 12 hours, however. A randomized controlled trial with those experiencing menstrual pain. The intervention was abdominal aromatherapy massage. Level and duration of pain and bleeding were significantly lower in the aromatherapy group. Randomized control trial for those experiencing low back pain. Acupoint stimulation for relaxation with electrode pads followed by acupressure massage. After 8 sessions with lavender oil, it was shown to be an effective method for short-term lower pain relief. Experimental study for those experiencing neck pain. The intervention was acupressure with lavender oil. Manual acupressure group experienced 23% decrease in pain intensity 1 month after ending treatment. This study found a significant positive effect of aromatherapy in reducing pain. These results indicate that aromatherapy should be considered a safe addition to current pain management procedures, as no adverse effects were reported in any of the included studies. Additionally, the cost associated with the aromatherapy is far less than the cost associated with standard pain management treatment. Although the present meta-analysis indicates a large positive effect for the use of aromatherapy for pain management, the sample size is small. Given the prevalence of aromatherapy, more research is necessary to fully understand clinical applications for its use. The effects of honey or lavender use on post-tonsillectomy pain relief among preschool children by Sana Ahmed Mohammed, Fatma Ahmed El-Sabski. Tonsillectomy is one of the most common surgical procedures performed worldwide in childhood. One of its main complications is pain. The aim of the study was to determine the effect of using honey or lavender essential oil to reduce pain after tonsillectomy among preschool children. Quasi-experimental research design was carried out. The research hypothesis was children who received honey or lavender essential oil use will have decreasing mean score of pain than the control group. The sample containing the convenient mothers of 150 were divided into 3 groups equally and referred to the pediatric clinic and ENT department in Benha University Hospital. The following tools were used to collect the required data. Tool 1, a structured interview questionnaire. which included mothers and their children's socio-demographic data, history of children, and mother's knowledge related to CAM. Tool 2, a visual analog scale VAS for pain assessment in the 3 groups were evaluated through 3 days after surgery. Immediately after surgery, the honey group was experiencing 2.6 on a pain scale out of 10. Lavender was 2.71. Control group was 2.61. After 3 hours, the control group actually experienced a decrease in pain as opposed to the lavender and honey group. Following the next 3 days, you can see that the honey group and lavender group all experienced decreased pain levels. Many studies investigate postoperative pain after recovery room. Although the intensity of the pain in all groups decreased after surgery, honey alone and lavender groups experienced more pain relief compared to the other control group. However, there was no statistically significant difference between honey and lavender and control groups immediately and after 3 hours. Oral administration of honey after waking up following tonsillectomy can reduce postoperative pain in pediatric patients and may substantially decrease the need for analgesics during taking honey in this challenging group. More studies are necessary to be performed to investigate mechanisms of honey pain relieving effects. There were some limitations in the study, such as disagreement of mothers in continuing their cooperation, the child's dislike for eating the lavender or honey. The differences regarding the VAS scores were not as significant. In agreement with this study, who showed that oral honey administration after tonsillectomy in pediatric cases may reduce the need for analgesics for relieving postoperative pain. The study concluded that honey or lavender essential oil use is more effective than control group to reduce pain after tonsillectomy among preschool children. More decrease in pain was observed in honey and lavender groups, but the difference was not statistically significant.
Comparing the effects of aromatherapy massage and inhalation aromatherapy on anxiety and pain in burn patients, a single-blind, randomized clinical trial. Findings. The study of 90 burn patients who had no significant differences in background variables and had the same anxiety and pain levels at the baseline showed that aromatherapy massage and aromatherapy inhalation both decreased the participants' anxiety and pain levels. Strengths. The sample size and having similar background variables. Weaknesses. The study had cultural limitations and only studied female burn patients. It also only examined patients' anxiety during a single interventional session. Future studies. It is suggested that future studies examine anxiety and pain levels from a male perspective. It is also suggested that anxiety is examined during several sessions. Feasibility. The low cost, wide availability of subjects, equipment and cooperation of a facility, and the researchers having a master's level's expertise. Risk of project. There are no identified risks because patients all had to meet inclusion criteria and sign informed consent to participate.
One of the research articles we chose to study was aromatherapy massage for neuropathic pain and quality of life in diabetic patients. The findings of this study is the neuropathic pain levels were significantly decreased in the intervention group by week 4 as opposed to the control group. The strengths of the study was the control group versus the intervention group. The weaknesses, there wasn't a follow-up after the 4-week mark, so the long-term effects of the aromatherapy for the neuropathic pain is unknown. Another limitation was the small sample size and the fact that they only use one clinical center, so there wasn't a generalized group of patients with diabetic neuropathy to study. In the future studies, it said to train the nurses in aromatherapy massage in order for the full effect and knowledge. Feasibility, it was simple and effective non-pharmacological nursing intervention. And risk of project, there were no risks identified.
Evaluating the efficacy of lavender aromatherapy on peripheral venous cannulation pain and anxiety, a prospective randomized study by Karaman et al. Karaman et al. Wanted to evaluate the effectiveness of a lavender aromatherapy on pain, anxiety, and level of satisfaction associated with peripheral IV cannulation in patients undergoing surgery. 106 patients undergoing surgery were randomized to receive aromatherapy with lavender essential oil or a placebo during peripheral IV cannulation. After cannulation, the pain and anxiety scores of the patients in the lavender group were significantly lower than in the control group. In addition, patient satisfaction was significantly higher in the lavender group than in the control group. Strengths to the study was a large sample size of 106 patients. Weaknesses to the study were that it could not be conducted as a double-blind study due to the odor of the lavender oil. The patients in the lavender group could not be blinded to the use of the essential oil, and the patients in the control group only inhaled pure water as a placebo, which has no odor. For future studies, research has proven anti-anxiety effects of aromatherapy with lavender. However, its analgesic effect is still unknown. Further studies confirming lavender's analgesic effect need to be conducted. The research study is feasible because the authors received no financial support for the study, and they declared no conflict of interest. There was a large number of subjects. There were no time constraints. Lavender essential oil was readily available. The data analysis tools were readily available, and the researchers were expertise in the phenomena. The research study produced no risks to health or safety for the participants. For our research study, we would use a quantitative quasi-experimental design. The independent variable would be the integration of aromatherapy with essential oils for pain relief. The dependent variable would be the patients receiving traditional PACU pain relief care. The target population would be PACU patients needing pain relief. The sample method would be convenience sampling. The sample size would be 100 PACU patients. And for the data analysis method, the normally distributed continuous variables would be evaluated using independent sample t-tests.
Prior to implementing. So prior to implementing the use of essential oils, the PACU nurses, the physicians, and the ancillary staff would need to be certified in the use of essential oils. Learn which oils to use, which oils to mix, how to use them, if there are any side effects. The certification can be provided through the Buffalo Wellness Center staff or through Roswell Park Cancer Institute staff. There would also need to be mandatory annual recertification just to keep up and see if there's any changes. Implementing. The stakeholders is the PACU itself in the hospital education department, because they would be involved in the research and implementing the use of the oils in conjunction with the analgesics, and the team providing the alternative pain management, which is the nurses, the doctors, and the actual post-op patients. The use of essential oils for pain management would be via diffuser, like inhalation aromatherapy, or topically, and they would mix the oils with the base and then put it directly on the skin. Integrate and maintain. The benefits of using essential oils. Less side effects than the opioids. Alternative medicines are becoming more accepted nowadays. There's no possibility of addiction with using oils, and it may actually implement lifestyle changes. If the patient sees benefits of using the oils, they may change it and use it in other aspects of their lives. The risks, it could be costly because insurance may not cover essential oils as an alternative. And some patients are reluctant to try any alternative management or medicine. And some essential oils may irritate the skin if applied directly. And integrate and maintain continued. How will you know if your change is working? Well, you would monitor the dependent variable, which is the patient's stated pain level. You would monitor the level, you would ask their pain immediately post-op, 8 hours post-op, 24 hours post-op, 7 days post-op, and then you would follow up as an outpatient 30 days and 90 days post-op, and see if they're still using the oils also. You would have knowledgeable staff providing essential oil use, ensuring proper technique and use, and that's how they would maintain their certification to keep up on everything. there would be a shorter hospital stay due to less pain, and in turn, the hospital stay, early ambulation, which would lead to less complications, which would lead to an earlier discharge. And the patient reporting adequate pain management with a conjunction of essential oils and analgesics, but there would be less side effects because you wouldn't be using as many opiates, hopefully. So there would be less nausea, vomiting, constipation, etc.
In conclusion, nursing is a science and an art for caring for human beings. Pain is often a reason why humans seek and need health care. Therefore, the assessment and management of pain are essential to the practice of nursing. Pain is a subjective topic and often undermanaged. Uncontrolled pain can be detrimental to one's health by affecting the mind, body, and soul. As a nurse, it is important to explore, research, and advocate for effective evidence-based practices to pain management. Thank you for watching our presentation, and here are our references.